Good morning, everyone, and welcome to our Allograft webinar session 4. I'd like to welcome our guest speakers, Mr. Clinton Parmenter and Yvonne Panek-Hudson, and all the participants that are joining us from around Australia today. The Leukaemia Foundation acknowledges the traditional owners of country throughout Australia and recognises their continuing connection to land, sea and community. We pay our respects to their elders, past, present and emerging. The reason we're holding this seminar today is that because we understand there are many unique and complex aspects of the allogeneic transplant experience, one that only those who have experienced it can truly understand. This webinar is the last of a 4-part series, each that has had a different focus on the journey of someone going through an allogeneic transplant. Today we'll be hearing from a person living with blood cancer who has had an allograft, and we'll be hearing about his personal experience with a particular focus on the late effects he has experienced and how he manages this. We'll also hear from Yvonne Panek-Hudson, a nurse practitioner with expertise in the late effects of allogeneic stem cell transplant. And the last 30 minutes of this webinar will have an opportunity for discussion amongst the group. We often hear that those going through allografts want to connect with others who are also going through this experience, and hence we want to provide this opportunity for participants. We'll draw out some themes from the information presented and share our experiences and learn from one another. And this will be facilitated by my lovely Leukaemia Foundation staff. Well, this morning we'd like to welcome Mr. Clinton Parmenter, and he lives in Nebo, which is about an hour and a half west of Mackay. He lives with his partner, Terina, and 4 of his beautiful children. Clinton was diagnosed with acute myeloid leukemia on the 8th of February in 2017. He underwent an allogeneic transplant on the 28th of June in 2017, and this was after he had had 3 rounds of chemotherapy that was unsuccessful. Prior to his diagnosis, Clinton had his own engineering business and successfully ran 11 other businesses. Since his diagnosis and consequent treatment, Clinton now recognises the value of being present, following passions and keeping active. He believes that engaging with others maintains connection and a zest for life. He now operates 5 of his businesses, enjoys family time, mountain biking and growing roses. I'd like to welcome Clinton. Thank you.
Thanks very much, Jane. Thank you. So my story, as Jane said, started back in 2017 when I was diagnosed. I was feeling fatigued, didn't feel very good, and my mum said, "You don't look very good." So I went to the doctor, and my doctor told me in no uncertain terms I might have had too many beers over Christmas. So he said, "But we'll do a blood test anyway." So yeah, the blood test got done, and we found out that, yeah, I had acute myeloid leukemia. I had my first round of chemo 4 days after being diagnosed. From that, I got an infection, and in the next 4 weeks, I spent 4 days in a coma. I got an infection in the Hickman in my chest. Come out of that, and then I proceeded to go towards a bone marrow transplant, which was to be in June, but I had to have 2 more rounds of chemo leading up to that. And then I did the preparation chemo, which in my case was Flumel. I went through the bone marrow transplant, spent my 100 days in the Wesley Hospital, and come out the other side. And it was a big turning point in my life. I met Mary Ann and her colleagues at Leukaemia House in Dutton Park, and discussions I had with them made my mind head towards better outcome. That's what I believe. I believe that 95% of, in my case, my result is from my mind being strong, and probably the other 5% is diet. So as I've said to Marianne in the past, I always believe the body is a V8 engine. And with that V8 engine, you've got to put in good fuel. And you put in good fuel, it performs at its peak performance. And it's the best way of having the body recover from what's going on with it. The same with that V8 engine. If you over rev it, work it too hard, you can cause damage to it, but it's still got to be run. So by running that engine at a moderate pace, it'll run for a long time. And I believe that's where the longevity is. So I started walking when I came out of my transplant, and it took me 4 weeks to get up to 100 meters, and because I'd been laying in hospital for almost 6 months. And from the next month, it took me another 4 weeks to walk a block. And from that next month after that, I walked down to South Bank from Leukaemia House. And in the end, I was walking to the Wesley Hospital, which was 9 k's each way. And I'd go from the Leukaemia House across there every second day, do my treatments, come back. And for me, that just kept me moving, kept me motivated. My body felt good. I wasn't out of pain altogether, but it made my body really feel good and energetic to deal with everything that was thrown at me on a day-to-day basis. As I went forward from that, I left Leukaemia House, come home, continued my walking, bought a mountain bike. And the silly part about that mountain bike is when I bought that mountain bike, I walked past it and I thought it was a good idea. And I thought, look, I'll ride that bike home. But I got about 500 meters up the road, and even though I could walk 9 k's each way to Leukaemia House, I couldn't ride a bike 500 meters. So it took me 3 months to get into that rhythm of doing it. But as I've always said, just little progressions and just keep moving forward, keep trying to improve yourself all the time. And that's what's worked for me. I've really had a lot of GVHD in the post-transplant days. It's probably 4 months post-transplant. Mine were anything from really bad fatigue, skin rashes, bowel issues, diarrhea. Not really bad that it lays you up in bed, but bad enough that you're in pain most days, but it's manageable. And I think everything that this disease throws at you is manageable. But to get to that position, you need the help of people around you, the doctors, the nurses, the counsellors that can help. Everything's got to keep working in a positive manner. And the positivity thing is everything that it needs to be. I always look at everything as half full instead of half empty. I suppose that's a little bit of being an optimist, but I think that's really contributes to how your diagnosis is going to progress. Everybody's different. Everyone likes different things. Everybody needs to be treated different. And I think the way the blood cancer treatments are going now, they're treating people individually because everyone's got the different chromosome, that different gene. And the same with how you recover from it. Everyone needs to be looking how they can do it in their way. Like I like gardening. I like growing roses. That's a passion of mine. I give it 110%. So if you like singing, if you like dancing, well, that should be your thing, to give 110% to keep moving forward, you know. My transplant come from my brother, and I think he's been on a previous episode of this. He's a great little fella. I've lost a bit of height having his stem cells transferred over to me because I was 6'1". I'm now only 6 foot, so I don't know how that worked, but he's sort of dragged me down a little bit, but I'm not holding it against him. So, but yeah, it's just everything's about that positivity and moving forward in a positive life. One of the analogies everyone says to me, what do you mean half full, half empty? And I say, well, you've got to look at things in how they can relate to you. So everyone says chemo is bad and painful and that, and it is. But for me, chemo was the best weight loss program I ever went on. So for me, that was the positive thing that come out of it, even though it was a painful thing at the time. So um, to me, that's what you've got to be doing, and you've got to keep dealing with the issues as they rise, manage them as best they can, but manage them in your way. And everybody's different. So yeah. So thanks very much for listening, and I wish everyone the very best. So thanks.
Thanks, Clinton. We really appreciate your honesty and sharing of your wonderful experiences as, you know, you've explained it. I loved the analogy of the engine, the V8 engine, the balance that's required along this journey, and the spinning negatives into positives and turning things into your favour. So I think that's some great themes and messages for everyone to take home today. So I'm now going to hand over to Linda, who's going to lead the questions for this part of this session.
So, Clinton, we were wondering, could you just tell us a little bit more about the GVHD, as in how, what that required from you, as in seeing doctors, medications, how long it lasted, or is it still ongoing? How you've managed to put that into your life, deal with it.
Yeah, so the GVHD is still ongoing. It's not as bad as it was 3 years ago. We've learned to manage it better, and that's trying different drugs. I won't go into what different drugs there was because everybody's different. But you know, the skin rashes and that, I used to have to get biopsies to see, you know, make sure it was GVHD. Um, you know, we tried different foods and that to try and ease the stomach issues, because the diarrhea was a big part of the GVHD. And it's all it is the body is trying to, the immune system is trying to reject the body. I heard Yvonne say before about how we relate the bone marrow transplant and to a organ transplant. You know, the bone marrow transplant is the bone marrow, and it's the thing that your immune system, I suppose, that's trying to repel everything else. So it's fighting against your body all the time. Trying to get to grips with that, you need to try different things, you know, and the doctors are all over that sort of stuff. So for me, it took a long time to manage it to where it is today, but I think they did a really good job. They're up to date how much they need to give you, what sort of steroids to give you to dampen down the immune system, so it's not attacking your body all the time.
So we've had a few questions come up in the chat as well. So one of the questions is, what sort of symptoms? So I know you talked a little bit about the symptoms earlier on when you spoke, but what other symptoms did you have, and how were they able to differentiate that as being GVHD as compared to a symptom from something else to do with the transplant?
Yep, sure. So the biopsies, they took biopsies of the skin rashes to confirm it was GVHD. These all happened at the same time. So as they give you more steroids and it dampens down the immune system, the effects got less. I had bone pain. I had neuropathy. The neuropathy was probably more to do with the chemo that I had, but it's still probably my biggest issue today. But all these things that you're going through and your body's going through, probably the biggest issue GVHD has on your body is your mind. It can really switch your mind to bad places from time to time. And they can give you stuff to stop that, to stop your mind dragging down. But I think you've got to be aware of what's going on with your body and get your mind to trigger back to that positive path again. And that then leads on to the GVHD, you know, suppressing and, yeah, the drugs they give you will help all that as well. So, but it's very draining on you, I suppose is the right word to say. It's draining on your psychology. It's draining on how you feel day to day, but you've just got to be aware of it and switch the switch that keeps you going on that right path. So.
Thanks for talking about that as well, Clinton. Actually, that was one of the other questions that had come up, was about how it went emotionally for you, how you deal with that, how you manage it. So it's great to hear that, you know, you think being positive and talking to your doctors about that is important. Another question that we've had come up was your blood type the same as your brother's?
Yes, it was.
Okay, so you
Yep.
didn't change. All right, great, thank
No.
you.
Yeah.
And I
One
think,
of the other things with the
yeah,
mind, if I could, sorry,
please
one of the
do,
other
please.
things with the mind is that I think everyone that's got any sort of cancers, you really have a lack of tolerance towards other people's issues. And I'm sure that a lot of people out there feel the same. It's something that you've got to suppress and be aware of, but you sort of have no tolerance for other people's trivial things that are going on in their lives. And not that I'll give you any examples because those trivial little things in their minds can be huge, but because of what you're going through, the pain, everything you're trying to manage, it does make your mind work overtime. So, yeah.
Thank you, Clinton. I think that's been very helpful for the audience. We much appreciate it. I'm going to hand back to Jane now to introduce our next speaker.
Thanks.
Yes, Clinton, thank you so much. I think it's important to recognise it's just not the physical components, but also the mental components that can be affected through this journey with allogeneic transplant. So thank you so much for sharing with us today. Our next guest speaker is Ms. Yvonne Panek-Hudson. Yvonne is a nurse practitioner in the Clinical Haematological Service at Peter Mac and the Royal Melbourne Hospital. She's a clinical lead for the Allogeneic Bone Marrow Transplant Long-Term Follow-Up Service and a team lead for haematology, late effects and paediatric specialist nurses. Yvonne has a special interest in late effects experienced by patients after allogeneic bone marrow transplant, particularly screening, risk reduction and self-management. Yvonne is also interested in sexual health issues, chronic graft versus host disease, and post-transplant rehabilitation. Yvonne has led and been involved in research studies focusing on innovative shared care models of long-term follow-up and strategies to optimise post-transplant recovery, including exercise programs. She has completed a research study supported by the VCCC Nursing Research Hub that explored facilitators and barriers to transitioning from paediatric to adult long-term follow-up. I'd like to welcome Yvonne today. Thanks, Yvonne.
I would like to spend some time with you today discussing how we, within our service, based on evidence, based on listening to our patients, based on our experience listening to our patients and the evidence, how we try to improve the long-term health of allogeneic BMT survivors. This is a passion of mine, and it's a passion that has been born and has grown out of working in allo BMT for 30 years now in a number of different centres, both in Australia and internationally, but most importantly, listening to what each and every one of you have taught me over time and, you know, tried to build that into a nice package. So here we go. So allo BMT survivorship really begins from the date of referral. So it's really important to start thinking about these things from the very, very beginning and integrating those concepts into early conversations with patients. So that's really important, both from a health provider perspective, but also from a patient and carer perspective. So, you know, starting to ask those questions of your healthcare providers early on. You know, what does this mean for me long term? What can I start to do now to improve my not only my survival, but my quality of life long term? Annually, more than 60,000 transplants are performed worldwide. And I was looking at the most current data from the Australian Bone Marrow Transplant Registry, and across Australia and New Zealand, there have been about 15,000 allogeneic transplants performed in the adult and paediatric sectors. And the use of transplants to treat various conditions is expanding considerably, and the utilisation of transplants is expanding just due to the availability of donors through haploidentical transplantation as well. And you know, I've worked in transplants for long enough, to see many long-term survivors. And I know for a lot of people, when they're coming into transplant, you're told all the bad stuff, you know, all the side effects that are going to happen and the potential risks, and you know, this you could, you know, end up in intensive care, or this might happen to you. But I can tell you from experience that there are a lot of really good news stories out there, and we see them in our clinic, in our practice every day. You know, and good news, there's a variation in good news. You know, some people have minor issues long-term post-transplant. Some people have more considerable issues. But our role in long-term follow-up is to try and understand what people's goals are, and to try and help them navigate their way towards those goals and support them to achieve them. So what we know is that for people who are alive and disease-free at 2 years post-allogeneic transplant, that their chance of being alive at 10 years post-transplant is in excess of 80%. Now, obviously, there's variable risk depending on what people were transplanted for and what type of late effects they have, and whether they have chronic graft versus host disease or not. But you know, when we throw all of that into one basket, we know that there's a, you know, a really good chance of living long term. And what our role in long-term follow-up is to ensure that for those survivors, that they have an excellent quality of life, whilst taking into consideration what people were diagnosed, what disease they were diagnosed with, what treatment they had prior to their transplant, because most people who come into allogeneic transplant, they're not a blank canvas. Like Clinton described before, you know, he'd had 3 rounds of chemotherapy before he came to transplant. So we need to take those things into consideration as well in long-term follow-up. The type of transplant that people had, whether it had radiation incorporated as part of conditioning therapy, what people's personal and family medical history is, and also what their health behaviours are as well. So we really consider all of those things, not just the transplant in isolation. So I know that my lovely colleague Alex Revaland presented to you, I think, a couple of sessions ago, and she presented this anatomy of an allograft big picture, and she talked about the early stage of transplant. Well, I'm going to talk about this bit here. I'm going to talk about long-term follow-up, but predominantly about the hopefully the sunnier days ahead for people. I will touch on chronic graft versus host disease, because you can't talk about long-term follow-up and late effects without incorporating chronic graft versus host disease, but I'm not going to concentrate on it because that requires a bigger session, which the Leukaemia Foundation may consider at a later stage for you all. So long-term follow-up is about survivorship. And survivorship provides a focus on the health and well-being of a person living with and beyond cancer. And I say living with because some of our patients who come to long-term follow-up still have evidence of disease. So this may be patients with a chronic leukemia, or patients with with multiple myeloma. So they may still have evidence of disease and be on some maintenance therapy, but they're coming to long-term follow-up for management of the potential and actual late effects associated with their transplant and the disease that they've had. Family members and caregivers are also very much part of the survivorship experience, and we encourage them to be involved as much as possible. They are such a fundamental part of not only the acute phase of transplantation, but also the recovery period, and are often forgotten in that early period of time. And often the physical and the psychological impact of their experience doesn't have its full impact until patients are 1 or 2 years post-transplant and getting a whole lot better. So it's really something that we feel is important to incorporate within our long-term follow-up framework. There's a little picture of our team with the patients. So our team is actually much wider than this, but our long-term follow-up service is proudly a nurse-led service. So I'm a nurse practitioner, as thank you for introducing me as that, and a nurse practitioner, for those of you who are not familiar with nurse practitioners, we are honoured to have undergraduate degrees in nursing, and we have postgraduate qualifications within our specialty, but have done additional postgraduate qualifications in order to practice autonomously. So to break that down, I can do a lot of things that doctors can do. I can prescribe, order medications, see patients independently, run services, but I practice with a nursing philosophy, and this is Teresa, who is a clinical nurse consultant who specialises in allogeneic bone marrow transplants, and is a fundamental part of our long-term follow-up service. And this is one of our wonderful patients who we allowed us to take this photo and share it because we were celebrating a clinic milestone on that day. But our clinic is very multidisciplinary. We have medical staff who attend, and we have specialist dermatology incorporated into our service, and lots of allied health team members who don't necessarily attend on the day, but who have active involvement. So we know that survivorship care is a complex area that encompasses transitioning patients off active treatment, providing support for rehabilitation and return to work. So we not only look at the physical aspect of long-term follow-up, but the psychosocial, the psychosexual, and the vocational aspects of long-term follow-up. But also planning for disease-specific and treatment-related follow-up, and providing community-based support as well, which is very, very important, and was a big project that we did a few years ago, and we developed some training platforms for primary care providers to upskill them in order to participate in survivorship care for patients after allogeneic transplant, so that people could have their survivorship care in a location best suited to themselves. So when you're thinking about long-term follow-up in allogeneic BMT, we always try and think about how we can be more innovative, and we can look at improvements within our supportive care framework. And this is for all allo-BMT survivors, regardless of where they are in terms of their survivorship. So, you know, at 2 years post-transplant, when people become eligible to attend our service, or 30 years post-transplant. And in our clinic, I see people that I looked after 30 years ago, which is absolutely sensational. And it is like a reunion every year. Because we know that allogeneic BMT and treatment that people have prior to coming to transplant is complex, and it may result in physical late effects, psychological distress, and also financial and employment stressors as well. And we know from our own experience, but also the evidence supports what patients tell us, and our own experience, that often patients and families are not completely prepared for the impact of long-term recovery. You know, that transplantation is not like having an appendectomy that you're kind of in and out, in a couple of days and then, feeling better after 2 to 6 weeks. That, for some people it can take a year or two, and for some people even longer, particularly if they have graft versus host disease. And that, what we need to do as healthcare providers in order to serve our population of patients well is to focus on non-clinical complications, as well as the physical and the clinical issues. Oh, and sorry, I just thought that picture there, I actually took that picture. So I took this picture in Salt Lake City, Utah, and I was at a transplant conference that I was presenting at, and it was amazing because it was snowing. I was walking back to my accommodation, and this was like an installation, obviously an astronaut that was suspended on the street, and I took a picture because to me it really encapsulated in imagery how some people describe how they're feeling after transplant. Oh, there we go. Okay, so some of us have been long-term converts in terms of survivorship care for allogeneic bone marrow transplant patients. It, have incorporated it into our practice for a very, very long time. A really, really important document that was published in 2004, which is available if you Google it. It was an article entitled From Cancer Patient to Cancer Survivor Lost in Transition. This really put cancer survivorship as a whole at the forefront of people's minds, and also recommended guidelines in terms of incorporating survivorship care for all cancer patients, regardless of complexity, and really pushed for having dedicated survivorship guidelines and clinical service delivery incorporated into all cancer care settings. And the big items that they felt needed to be incorporated include prevention. So obviously prevention of recurrence, but also prevention of potential late effects associated with cancer and its treatment. Surveillance, not only for recurrence, and in the long-term follow-up space, although we're obviously always mindful of recurrence, it's sort of less something that we think about less, but new cancers and other late effects, so cardiotoxicity, osteoporosis, and other things that we'll talk about shortly. Interventions, so intervention for issues that are identified, but also intervention in terms of adjustment in health behaviours, so incorporating healthy eating and exercise, the things that Clinton described earlier. Intervention in terms of psychosocial health as well, psychosexual health, intervention in terms of assisting people to reach their goals and return to whatever vocational goal they may have. And also coordination. So a really important part of what we do in long-term follow-up is ensuring people are being connected with the best specialists that have experience in what their needs are, but also coordination between the tertiary team and the primary healthcare team as well, making sure that people are really well connected with their GPs and their GP nurses, so that they can receive care in the community, and that all of their healthcare needs are being met by the best people within their healthcare team. So what are some of the challenges of allo-BMT survivorship care? So challenges are not negative things necessarily. Challenges invigorate us to do better, and to think about what we're doing all the time. Because what we don't want to end up with is, I don't know if you can see that diagram, but it's from the New Yorker magazine, which is a great magazine. They have these fantastic diagrams with captions that are often the public, so the readers contribute them. So we don't want our patients to end up like this. So as you can see, healthcare is so complicated you may never get well. We don't want allogeneic BMT to be viewed like that. So what do we know about allo-BMT? We know that the aim is that it is curative. Sometimes it is not. Sometimes people do relapse after transplant, but the ultimate goal of allo-BMT is curative therapy. We know it is complex, and we know it's complex because it is intense therapy. It requires long hospitalization. There are lots of different medications that we use to immunosuppress people in order for the transplant to be successful, which then require supportive care in terms of anti-infective therapy. And we know that that's challenging both physically and psychologically for patients and their families. We know that all of that results in cumulative toxicity, which then, coupled with the toxicity of treatment that people experience prior to transplant, adds an extra challenge in terms of survivorship care, but something that we need to always take into consideration, and we do in our practice. We know that recovery takes a long time, and we have to prepare patients and their families for that. You know, we need to ensure that we're sending the right message and that we're helping people have realistic expectations and set realistic goals. Graft versus host disease is obviously a challenge in this space. We know that for 25% of our patients, transplantation is undertaken far from home. Jane, who's on this meeting, one of our co-hosts today, knows that very well, having been a wonderful public servant to the Tasmanian population of blood cancer patients for a long time, knows that many patients come from outside of metropolitan areas, and so they need additional support, but also we need to consider how we provide their survivorship care closer to their home, not bring them back to us long term. As I discussed earlier, we know that survivorship care has an impact on carers too. They need to take days off work to accompany people to their visits. They may have their own health issues, both physical and psychological, and we need to consider all of those things, as well as the cumulative impact of having been a carer during the acute phase of transplantation and then moving into that survivorship phase. And another thing that we know is a challenge is that, and we really understand this, so I don't want you to think that I'm being unsympathetic, but we know that allo-BMT patients are traditionally wedded to their transplant centres, and often because we are experts in allo-BMT, patients like to come to us for every aspect of their care. So what we're working on, as I said before, is trying to support and educate and mentor referral centres and primary care providers in order to upskill them and give them the support that they need, the mentorship they need and the confidence they need and their patients need in order to provide survivorship care in locations that are more convenient for patients and carers. So the goals of allo-BMT survivorship care include screening, identification and treatment of potential and actual late effects. And this is very broad. You know, some people get some small minor issues that are really easy to manage, and some people get more significant things. So it is a trajectory. It's not a one-size-fits-all. In addition to that, screening is not a one-size-fits-all as well. We try and screen according to patients' history and their need as well. As I've already mentioned, we take into consideration prior treatment, current and past health behaviours, family history, and evidence-based community recommendations. We incorporate education and counselling. We encourage self-monitoring and self-management as much as possible. We're really big on community screening adherence. So, you know, getting your bowel cancer screening done, attending breast screen, getting your skin cancer checks, eating healthy, doing regular exercise according to the World Health Organization and Heart Foundation recommendations. We incorporate psychological support and referral. I know that for some people, particularly our younger population of patients, that fertility is a really big question in people's minds. And so for patients for whom fertility assessment and counselling is relevant, we will help facilitate that, both in terms of having those conversations with patients ourselves, but also referring them to the most appropriate people, because not everybody is infertile post allo bone marrow transplant, although for most people fertility is impaired and some people do become infertile. It is really important to consider that some people are not infertile post-transplant. And so we also then need to incorporate conversations about utilisation of contraception as well. So sexual health conversations are really, really important. Vaccination adherence. So vaccination adherence is very, very important. We have a really solid post-transplant vaccination program within our wider BMT team, but we understand that many people receive their vaccinations in the community, so we can certainly provide advice based on Australian immunisation recommendations. Identifying goals and assisting with navigation. So what we do in our clinic is we ask people who come to see us on an annual basis to identify what their goals are for the coming 12 months, and we identify ways that we can support them and assist them with navigating towards achieving those goals. And then in the at the next visit 12 months later, we look back on those and identify, well, one, celebrate success, but also identify areas that may need a little more assistance. Data collection is a really important part of survivorship care. For a long time, survivorship care, including allogeneic bone marrow transplant survivorship care or long-term follow-up, was a bit of a data-free zone. And so a lot of what we did in terms of developing protocols was based on our a long-term experience, but there's a lot increasing amount of emerging evidence in terms of screening and management of long-term issues that people experience, and it's really, really important that we collect this data, because it informs how we practice in the future, and certainly has an impact on improving quality of life for patients. Connection with primary care providers is a really important part of what we do as well. So and this is obviously includes the care and best location for person and family carer. So we will pick up the phone and have a conversation with primary care providers about particular issues that we identify or things that we feel are best dealt with within the community. As part of our survivorship care model, and I'll show you a copy a little bit later, we have a survivorship care plan, and patients' GPs as well as patients get a copy of that. And so we encourage patients to take their care plan to their GP and have a conversation with that after they've seen us. Oh, we also have a rapid contact address for patients and GPs that they can get in touch with us if they need to. So that's really important as well. Okay, so this is one of those really confronting slides with lots of information about the possible late effects, but really important to discuss. And I'm not going to go over everything in detail, but I'm going to pull out some items that I know people ask about a lot. So I'm actually going to talk about psychological health on the next few slides. But I will talk about neurocognitive deficits. There's some really important work being done in New South Wales and also in Victoria. There's a clinical nurse consultant at the Olivia Newton-John Centre in Melbourne. The Olivia Newton-John Cancer Centre, Wellness Centre in Melbourne, who is doing her PhD on cognitive health after treatment for cancer. So, and they're doing some really nifty things, using MRIs, but also looking at interventions to try and improve cognitive health. Reports of cognitive deficits vary after LO-BMT. We certainly see in our experience and in the literature that people who have had total body irradiation or any radiation that involves the brain do report neurocognitive deficits more frequently than patients who don't get total body irradiation or radiation to the brain. There is a relationship, of course, between neurocognitive deficits and psychological health, but also with fatigue as well. And the big piece of advice around neurocognitive improvement and health is, and you won't be surprised by this, is incorporating healthy eating, doing regular exercise, doing a variety of brain training exercises, so crosswords, reading outside of your scope, doing Sudoku, and being socially engaged, which I will admit is very hard at the moment, particularly if you live in Victoria. So they're the sorts of pieces of advice that we give to people who do come to us and describe neurocognitive deficits. And the things that people often describe are things such as short-term memory issues. So, I've got 3 things to buy at the supermarket. I got to the supermarket, I could only remember 1. I know I needed to get to location D, and I needed to stop at B and C on the way from home, but I got to location D and I didn't stop at B and C. So we talk to people about writing things down, keeping lists, referring to those lists regularly, keeping notes on their smartphones. So that is an issue that people bring up. The other thing I would like to discuss is bone health. So, and this is where I think it's really important to talk about, and I'm going to just jump to the next slide and then move back. So chronic graft versus host disease. So chronic graft versus host disease, as you know, graft versus host disease is a disease of the immune system where the donor's immune system identifies the recipient's body as foreign and mounts an attack. The risk of chronic graft versus host disease is variable. It is around 40%, but it depends on what type of transplant you have and who your donor was. but also the scale of graft versus host, chronic graft versus host disease varies. Most people have a very mild form of chronic graft. Well, most people don't get it. Some people get it a mild form to moderate form, and obviously there's a small percentage of patients who develop more significant chronic graft versus host disease. It can affect a number of different areas. It can affect the eyes, causing dry eyes. Can cause changes in the skin, so skin thickening called scleroderma, can cause a rash, can affect the nails and the hair, causing alopecia. Can affect the genitals, particularly in our female patient population. They can get genital tract graft versus host disease. The digestive system, the oral mucosa, and the lungs less frequently, but this can be more significant if it does affect the lungs. As you know, from your reading or from personal experience, first-line therapy, and to this day, the best treatment for chronic graft versus host disease is corticosteroids, prednisolone, which can have a significant impact on bone health. It can affect the bone matrix, leading to osteoporosis in the more significant form, or low bone density, which is osteopenia. So this is something that we do monitor for in the long-term follow-up space, but again, counsel people on how to minimize the effect through diet, ensuring people have an adequate amount of calcium in their diet, but also through weight-bearing exercise. The other thing that I will touch on are solid cancers. I know that that is something that people are interested in, secondary cancers after having an allogeneic transplant. Although there is a risk of secondary solid cancers, can I please reassure you that the majority of solid cancers that we see in people after allogeneic transplant are skin cancers, and they are usually non-melanomatous skin cancers, meaning they're usually not melanoma. They're usually basal cell carcinomas or squamous cell carcinomas. They are more commonly associated with people who have had total body irradiation, and in people who have had or who have existing cutaneous or skin graft versus host disease. We infrequently see breast and thyroid cancers. They do occur sometimes, but are not common at all. And occasionally we do see secondary oral cancers. And again, they are more commonly seen in people who have existing oral graft versus host disease. So again, examining people's oral cavity, ensuring that they're connected with a dental oncology service for follow-up is really, really important, or if they're in the community, with their local dental service. So, you know, when you come to see us and we say, have you seen the dentist recently? And you say, oh, I hate the dentist. And we say, we'd really like you to go and see your dentist. There is method behind our madness. Okay, so I'm just looking at the time. So just moving on, we've talked about graft versus host disease. I want to talk about psychosocial health. So psychological distress and depression are prevalent, particularly in the early period post allogeneic transplant, and can take 2 years to plateau. You won't be surprised to hear that there is a higher incidence in people with chronic health burdens, particularly people with chronic graft versus host disease. And so we do see a higher incidence of anxiety and depression in people with persistent and more significant chronic graft versus host disease. So making sure that, you know, we identify that within long-term follow-up, and then make appropriate referrals either in-house or within the community for psychosocial review and management is really, really important. But also talking to people about their lifestyle behaviours as well. So ensuring that they are exercising regularly and engaging socially, so doing things to manage their own psychosocial health as well. We know that the changes in people's roles within their family circumstances, within their employment status and their financial circumstances are common stressors that our patients do tell us about, and that the impact on family, including overall burden of being carers and the financial burden and all of the things I've described, so things like change in role, are commonly reported, not only for the patient themselves, but also for their loved ones. There is a gender disparity, with men identifying less social support but better sexual function post-LO-BMT. And women identify more emotional distress and sexual dysfunction, but better social support after Allo-BMT. In 2 to 10 year Allo-BMT survivors, family and caregivers report strain and general uncertainty slowly declines over time, so that they over time start to feel better in themselves as well. And you'll be pleased to know, and there's a lot of work being done out of the Seattle Cancer Care Alliance, or the Fred Hutchinson Cancer Centre, as it's also known, that there are many Allo-BMT survivors that report positive changes in life outlook and perspective and ability to face future challenges as well. And I think Clinton really highlighted that in his presentation as well. So quality of life. So this is actually some of our data that we looked at. So the red line here is the baseline Australian population reporting on quality of life. And so this is through the Australian Institute of Health and Welfare. And what we found when we looked at our own data was that males and females were significantly lower on the physical and emotional well-being scale, but significantly higher on the social well-being scale. And males scored higher and females lower on functional well-being after transplant. When we looked at our employment and our vocation data, and this is something that is really important to us, and we're actually, this is work that we're going to be doing over the next couple of years. This is the priority for our team, looking at how we can support people to achieve their employment and vocation goals a whole lot better, because we know this is a gap in our service delivery. So when we look at our looked at our patient population through our questionnaires, 93% of women and 94% of men were working or in active study at the time of their diagnosis or commencement of treatment, compared to 47% of women and 50% of men were working or in active study at their first long-term follow-up assessment. So that's at 2 years. So that's a significant decline in engagement in employment and study. And the group most affected were those 45 years or older at transplant. And so what we're doing now is we're pulling that data out of our database, and we're going to try and characterize that a whole lot more and develop some strategies to assess people in a more well-defined, sensitive way, and develop some interventions and some connections both internally but also with community services to help support people get back to work and study if they want to. That's the other thing as well. And it's really, really important to help people achieve their goals, what they want to do. Sexual health is really important, and we incorporate this into our assessments. We know that sexual dysfunction is more prevalent in people who have had Allo-BMTs compared to healthy, in comparison to healthy subjects or the general population. It's often not a primary concern early post-transplant, but becomes more meaningful over time. But we also need to consider that some issues are pre-existent and persist or become more significant post-transplant. So, we also need to understand that although we can help, we can't fix everything. That the physical and the psychological are interconnected. And so, how people are feeling in terms of fatigue or stress, anxiety, has a significant impact on their physical functionality, including their sexual functionality as well. But from what we know from experience and from the literature is that if sexual health needs are not addressed, it can lead to significant distress and feelings of personal failure, relationship breakdown, and social distress. Studies have identified a gender-associated difference with women having an increase in an increased number of sexual health issues over time, and that 80% of women reported one or more sexual health issue at 3 years post allograft, as opposed to about 30% of men. And this is often related to early onset menopause that women, not all women, but most women experience, but also the impact of genital tract chronic graft versus host disease. And overall, for men and women, issues can include decreased interest, decreased pleasure, decreased activity, erectile dysfunction, issues with orgasm, ejaculation, impact on physical experience, so self-perception, vaginal dryness, and also pain disorders for both men and women. So what are our goals? We've talked a lot about this already. So monitoring, education, so related to health behaviours and disease risk reduction. So we really try and empower people to be involved in this as much as possible. Talked about the importance of collecting health-related information. So we ask patients to complete questionnaires on an annual basis, and as a one-off, we ask them to complete consent forms if they're willing to, in order for us to use that information in a de-identified way to do research projects in order for us and other centres to improve practice. Obviously, specialist referral is really important because, you know, although we're good at what we do, we can't do everything and we don't know everything. And there are sometimes people who are much better placed to address issues than we are. Our goals are to provide long-term support for transplant patients and families. And as I say to people, the only time that we will disconnect our relationship is if people electively choose to no longer attend our service, but our commitment to our patients is lifelong. We provide education and encouragement, as I said, to self-manage, but also to achieve goals, but also to incorporate person and family carer involvement. I have discussed some of this, but patients attend annually from 2 years post-transplant. We accept referrals from all over Australia and an increasing number of young people who are transitioning from paediatric long-term follow-up into adult long-term follow-up. And we've recently published a paper on the facilitators and barriers that young people experience transitioning from paediatric to long-term follow-up. So if that applies to anybody here, I'm happy to circulate the link to that article that we've recently published. We complete blood tests, patients complete surveys and investigations pre-review. Our consultations are 1 hour and they begin with a nurse consultant review. So that's with Teresa, who reviews surveys. She takes some general measurements, height, weight, etc., vaccination review, education, referrals, consultations with allied health, and a conversation about community screening adherence. We review patients' goals, and then patients come in for their medical practitioner or nurse practitioner review, which incorporates a whole of person approach. We make recommendations based on guidelines, so it's not a one-size-fits-all set of recommendations. We're really, really lucky that we have a dermatology service that runs in parallel with our service, where patients can have full skin checks, particularly patients who have been exposed to radiation, who on the day of clinic, we identify a new lesion on their skin. They can be reviewed on the day, but this clinical service also offers a service for people with chronic graft versus host disease of the skin. We have a lot of really engaged, passionate specialists and allied health professionals who love looking after our patients and who we can get our patients in to see quite quickly. And as I mentioned, we also develop a care plan for each patient, which we update on an annual basis and then send to them and their GPs and to their referring hematologists and anyone else they want us to send it to. And I think that's next. Yeah, so that's the front page of our care plan, and this is now on our electronic medical record. So if patients are signed up to the Health Hub, they can then see this within their record. So just to finish up, these are all really important aspects of what we do. We know that the majority of our patients do incredibly well post-transplant and need a little bit of our support. Some people need a whole lot more, and we're happy to provide a service according to what people's needs are. We have incorporated telehealth. In fact, we were early adopters of telehealth prior to COVID because we were really early innovators in terms of the ensuring that people could have their survivorship care in a location best suited to them space. So when COVID struck, we were able to expand our telehealth service delivery model very, very swiftly because we had already embedded it in our standard of care. GP shared care, which we do with many patients, coordinate their long-term follow-up with their GP, but now increasingly with their providers in other states. So for example, in Tasmania, liaising with providers, specialist nurses and doctors in other states in order for people to complete their reviews and their investigations locally. Multidisciplinary care. So the patient at the forefront of that with all of their multidisciplinary providers. But also really encouraging people to be active participants in their long-term follow-up and their long-term good health through incorporating exercise, healthy eating, and also community surveillance. And I've just also got a little diagram there, really acknowledging the importance of considering our model of care long term to ensure that we're servicing the needs of young people who are moving from the pediatric space into the adult space. So I'm going to stop talking now and say thank you very much, and to say this is our email address, longtermclinic@melbournehealth.org.au. We do take referrals from elsewhere, but we're also very happy to, we will often talk to other centres who are interested in developing clinics within their own hospitals, within their own existing models of care. We're always happy to share what we do with them in order for people to be looked after closer to home. So thank you very much.
Thanks, Yvonne. The passion and enthusiasm that constantly wells from you has created this enormously informative seminar that you've put together for us. I think it identifies that there is quite high complexity and challenges involved in survivorship care for patients post-allo transplant. And I loved the messaging that you were sending about it being patient-focused care and ensuring that we were working towards individual goals and things that were achievable also. Connecting to primary healthcare workers is essential, and I think that you've given some great tips how people can follow these things. So I'm going to throw over to my colleagues, who I know there's been a lot of chat and questions coming through. So thank you, Linda and Marianne.
Hi, Yvonne. That was great. Thank you very much. Appreciate your time. So we have, like Jane has said, we've had quite a few questions and comments come through in the chat. One of the questions that came quite early on is about graft versus host disease, and whether it's something that can resolve by itself or whether it always will require some form of treatment to help it disappear and go. If you would be able to give us an
Yeah,
answer.
absolutely. Absolutely. So, look, I'm pleased to be able to tell you that not everybody needs to have corticosteroids, prednisolone, or other treatments, so second line treatments such as cyclosporin or mycophenolate or other treatments. So some people can have topical therapies. So for example, if they have some mild skin graft versus host disease, we can use creams to manage that. Again, in the oral cavity, we can use topical mouthwashes or creams in the oral cavity to manage that, and also with dry eye syndrome, so which is related to ocular graft versus host disease, we can use eye drops instead of people having to use oral therapies. So, but it depends on the severity of graft versus host disease as to whether people need oral or intravenous therapy for it. But there is a spectrum of treatments that we use depending on what people present with.
And just furthering on that, I know that you did discuss about the treatments that come with graft versus host, the corticosteroids and such, destroying or affecting bone health and that in the future. Are there other side effects that can come from having those treatments that people need to be aware of?
Absolutely. So corticosteroids, although are an absolutely necessary part of particular types or severities of graft versus host disease, are not without toxicity. So I will begin with it can cause psychological issues. So some people find that it affects their mood. Some people feel quite high when they're on steroids, and some people feel quite low, or some people swing in between. It can affect bone health, as I mentioned. It can affect how people's bodies metabolize fats and sugars. So people can be at increased risk of developing type 2 diabetes. They can increase people's risk of developing high cholesterol. Steroids can also increase people's blood pressure as well. Now, some of these are short-term things that resolve after we take people off corticosteroids, and for some people who need to stay on corticosteroids, that can result in these side effects being more long-term issues that we have to manage in parallel with chronic graft versus host disease. So there's some of the other examples. Obviously, one of the other things that people will know is particularly for more higher doses is weight gain. People having basically people accumulate fluid in areas that don't usually accumulate fluid, but also losing muscle tone as well. So becoming feeling quite functionally weaker because of loss of muscle tone because of steroid toxicity, prednisolone toxicity. So again, all of those things, bone health, management of or risk reduction of diabetes and cholesterol, maintaining functional ability, require not only us as a healthcare team ensuring people are on the lowest dose of medication that they can possibly be on. So that's a really important part of what we do, but also supporting people and encouraging them to self-manage through making healthy dietary choices, but also exercising as well. So we've done a couple of just to segue a little bit, but this is really important information, is that we've done a couple of really important studies and we've published them. And again, I'm happy to circulate them. They're not written in ways that are impossible for most of us to understand, but we've written a couple of really important articles about the importance of exercise during and after transplant. and we've run programs and collected data along the way in order for us to support that recommendation that exercise is really important, not only after transplant, but during transplant as well.
Thank you for that. One of the other pertinent topics at the moment, obviously, is COVID. And so we were just wondering what sort of key messages your team talk about with people in regarding things like vaccination for COVID, if you wouldn't mind expanding on that for us.
Absolutely. So firstly, I will say that the decision to be vaccinated needs to be discussed with your individual medical provider. Okay, so that's a really important message because I don't know everybody on the call. However, unless there is a specific medical reason for you not to be vaccinated, our recommendation is that patients get whatever vaccine is available to them at this time. So we are recommending that our patients are vaccinated unless there is a specific medical contraindication to them receiving the COVID vaccine, and that they should receive the vaccine that they have access to at this time. And so you know, the other thing to mention is that allogeneic bone marrow transplant patients, doesn't matter how long ago their transplant was, are eligible under the 1B cohort. So the eligibility for COVID vaccination for allo BMT transplant patients has been open since February, I believe. So it's really important when you have a look at the eligibility criteria on your individual states. And I know it may look different state by state, but if you have a look at the eligibility criteria, having had a transplant at any time makes you eligible. But if you have any problems, and look, occasionally we have patients who are having problems getting their vaccines, just talk to your healthcare providers, nurse, doctor, and we'll provide you with documentation that supports you getting your vaccine. But we can't say that you're eligible for a particular vaccine over the other if in fact you're not.
Just mindful of time, so one more question. I know you talked a lot about, people being very attached to their transplant team that cares for them, and trying to build relationships with people like your GP, and getting care from them. Just what can a patient do to help that process, to build, if they have a very good GP that they think is very attentive to them, but still doesn't fully understand their needs or the transplant or their blood cancer, is there anything that they can contribute to that, building that relationship between you, and the GP?
So that is such a great question. I absolutely love that question. So firstly, everybody needs a GP. And if you don't have a GP or you're not happy with your GP, talk to your healthcare provider or talk to other patients that you know, because they will know of someone that they're engaged with and can make a recommendation. What I recommend is that after transplant, so after discharge, that patients go back and see their GP as soon as possible and have a conversation with them. You know, this is what it was like for me. And that if their GPs aren't receiving information from their transplant centre, that either the GP contacts the transplant centre and says, hey, we're not getting your letters, or the patient, eyeballs their healthcare professionals when they come to their appointment and says, my GP's not getting letters from you. Can you please send them? So that's super important. In long-term follow-up, what we encourage people to do is once they receive their care plan, they can be, one is making sure that your GP details are up to date in your treating hospital. So that's really important. And we do check that in long-term follow-up because people move around or they, change GPs retire. So making sure your GP details are up to date. Then when you've received your care plan, make an appointment, go and see your GP and talk about, you know, what the care plan has in it, what the recommendations are, because often within the care plan, you'll see on the front page that I posted before that I'm pretty sure I can put that back. See, I've got their summary of recommendations, LTFU clinic to arrange, GP to arrange, patient to arrange. So, you know, go in with your care plan and say, oh, look, you know, I know you've got a copy of the care plan from the Royal Melbourne Hospital, and they've recommended that I have an echocardiogram, but I don't want to go to Melbourne for that. Can we please organise that, you know, in Launceston or in Hobart or in Bendigo or wherever the patient may be, or, you know, even in Melbourne, but closer to home. So, yes, that's a great question. Thank you for asking that.
Thank you very much. I'll hand back over to Jane.
Thank you, everyone. And look, I just think we'll just summarise quickly on the themes that we've been through today of the uniqueness and the complex aspects of an allo bone marrow transplant, and focusing on patients and their needs, empowering patients, and the importance of connectivity to the primary care providers. So I'd really like to thank Clinton and Yvonne for their talks today and insights, and all of the participants for attending.